So in summary, fertility is generally comparable to non-IBD women. There are some exceptions. Surgery, as we talked about, particularly the IPAA and the risk for infertility post-J-pouch, and in Crohn's disease, and specifically if it's more colonic versus small bowel. Pregnancy and birth outcomes are best if the patient is in remission at the time of conception. I want you to remember that 1/3 rule. It's a good rule of thumb to tell your patients in regards to if we achieve clinical remission as well as, more importantly, mucosal remission, you will more than likely do very well throughout your pregnancy because that's unlikely to trigger a flare during your pregnancy. But if you have active disease or active inflammation, you're at a much higher risk, a third, at least 60% risk of having either worsened or ongoing active inflammation. It's important to be able to evaluate our patients and determine if they're having a disease flare at the time or during their pregnancy, but recognizing that we have to be careful with which modality we use. And remember, those laboratory values are not very useful during pregnancy. The best approach to evaluating during pregnancy as far as the mucosa is either with a flexible sigmoidoscopy, again, unsedated, best during the second trimester regardless, as well as, or as needed, an MRI without contrast because gadolinium, again, is a category X. Most IBD treatments seem to be low risk in pregnancy. Remember, anti-TNFs, category B. Really emphasize that to your patients, particularly if they're looking more at steroids, category C, or these antidiarrheals, category C, to control their symptoms during pregnancy. Mode of delivery should be considered as a case by case. We do not say all patients need C-section and remind our patients that as well. But the biggest bullet point, and I put at the very end, and I probably should have actually started my talk with this as my first bullet point, is that this absolutely needs to be a multidisciplinary discussion. A discussion most importantly with your patients to include, of course, the gastroenterologist, the obstetrician, as well as the pediatric providers. And I will add, and I didn't have a slide on here, but because I didn't comment on this, the anti-TNFs, because it crosses the placenta and is detected, the main vaccine that we do not want our babies to be exposed to post-delivery, and once they're delivered, the baby is, for 6 months, the main vaccine is the rotavirus. And so that's a virus that's a live vaccine that we do not want our infants and babies to be exposed to. The rest of those vaccines, per natural protocol, can be abided by in general and should be safe for the infant. With that, I thank you for your attention. And I ended in 40 seconds.